guys want to make sure that you do go over your cranial nerves information at home. Make sure you're looking over all of those 12 nerves, what they are called, what number they are, what they do, whether they're sensory, motor, both, and then what they're responsible for. So we won't be doing all of that in lecture, but you do have all of that on your Canvas module. For the fourth portion, 4 major parts of the brain, right? Cerebrum, diencephalon, brainstem, cerebellum. For this fourth portion here, the cerebellum, we're going to be talking about things that you'll want to reference to, like somebody who's really good at sports, maybe like your favorite basketball player. So for our family, that's going to be LeBron James. If you're not a basketball fan, maybe soccer or football or something of that sort. But the cerebellum, you will see that its role in the muscle coordination and movement and those very fine-tuned movements are incredibly important for these professional athletes. So when we're looking at the cerebellum, there is the cerebellar cortex, which is gray matter. Remember, we have gray versus white, unmyelinated versus myelinated. So on the outer cortex of the cerebellum, you will have the gray matter, just like on the outer layer of the cerebrum, you have the cerebral cortex. That is also gray matter. So same kind of setup here. The folia are the folds in the cerebellar cortex. For whatever reason, they decided not to call them the gyri. So in the cerebrum, we see them as gyri. Here in the cerebellum, we see them as folia. There are 3 lobes. There's the anterior and posterior and flocculonodular lobe. So 3 separate lobes to the cerebellum that is divided into hemispheres, just like the cerebrum is. So right versus left. And then there is this structure that runs right down the center of those hemispheres called the vermis. And this is a very narrow band of cortex that is involved with posture and eye movement. So the things that allow you to stay upright throughout the day are involved with that particular structure within the cerebellum. Now you can see here, as we look at this picture, that it does look like a little miniature cerebrum, right? You have the folds or the folia, you have the different lobes, you have the vermis running right down the center. It does look kind of like a worm. Okay, so whenever you're looking at it in lab, you'll be able to see multiple different structures from different views, but it is just like a little baby brain, a little small cerebrum. Inside of the cerebellum, we have this Purkinje cell layer, which is very important within the cortex, because in this Purkinje cell layer, you will have each cell receiving input from up to 200,000 synapses. So there's a lot of information that is going to be transmitted through the cerebellum. The arbor vitae, or vitae, depending upon where you're from, also known as the tree of life. This is just an AKA, the tree of life. This is highly branched white matter. Okay, so that myelinated axon, the white matter within the cerebellum. They call this the tree of life because it literally looks like a tree. This is going to have cerebellar nuclei that will relay information to these Purkinje cells so that we can have our synapses working appropriately within that cerebellum. Again, the functions of the cerebellum: adjust postural muscles and then program and fine-tune conscious and subconscious movements. So whenever you look at LeBron James play basketball, which is obviously what we've been doing a lot of here lately, you will see that whenever he runs up and down the court, he's very intentional about what he does, but you can tell that it does not take a lot of effort. His body is used to it. There's muscle memory. He knows how to do anything from any position at any point on the court against any player. So he's very, very particular about what he does with his body as well. If you're not familiar with this little fun fact, LeBron James spends $1.5 million per year on his body, just his body, because he knows that at the end of the day, it's going to either make him or break him. So he's very intentional about the foods that he eats, the exercises that he does. He's very, very logistic and meticulous about making sure that he's taking care of all of the different aspects of his physique and his physiology that will help him to be that incredible player that he is. So Cerebellar peduncles, that's a funny word, right? Peduncles, these are tracts that will link the cerebellum with the brainstem, the cerebrum, and the spinal cord. We have a superior, middle, and inferior portion. Of course, this is going to allow that consistent and constant communication amongst different parts of the brain. So the cerebellum does have the ability to talk to different parts of the cerebrum that are going to be necessary for motor output. So again, if we go back to LeBron, same thing. All of these functional areas have to be able to communicate efficiently in order for him to be able to do his job. So his is just on a very, very high level. If you see people who tend to be a little bit more clumsy or they fall, that could be the cerebellum. It may be other things. They may be drinking more than they let on. But whenever you're looking at the different levels of professional athletes and how their muscle coordination and their muscle memory is, it's very different from those of us who do not always do those particular types of activities. So the brain has to be very healthy in these athletes, especially the cerebellum. If we have disorders of the cerebellum, we could call this ataxia, which is going to be a disturbance in muscular coordination. There are multiple different reasons why this could happen. Ataxia is sometimes even hereditary, which is unfortunate, but you can see here some other issues that could come up that could cause this disturbance in muscular coordination. If you want to look at a video to see what this actually looks like in real life, there's a little link. I'm not going to watch this video. I'm not going to have you guys watch it right now. But if you want to go back to this later on, then by all means, I do encourage you to watch that video so that you can see what it looks like for someone who really does suffer from their cerebellum not being able to properly communicate and to work efficiently, as we all, kind of take advantage of ours every single day. Here's a little graph type picture for you. For those of you who like this, this breaks down all of the different structures that we've kind of already talked about a little bit, except for these transverse pontine fibers. Didn't mention that one, but what you can see right here is that the cerebellum sits posterior to the brainstem. And so right here, there is going to be a link between the pons and the cerebellum. We call those the transverse pontine fibers that will connect the pontine nuclei with the opposite cerebellar hemisphere. So if you like that, use that. So that's the last portion of our 4 major parts to our brain: cerebrum, brainstem, diencephalon, cerebellum. Which one of those is going to contain the pineal gland? Which of those 4? You guys remember? Diencephalon. Okay. Which one of those is going to contain the structure called the corpora quadrigemina? Superior colliculi and inferior colliculi. Midbrain, okay, specifically for the brainstem. If we're thinking about the brainstem, whenever you think brainstem, you want to think about a couple of different things. Breathing and being alive. Remember breathing and being alive? Because the brainstem has the reflexive centers for the cardiovascular system and the respiratory system. So remember that brainstem, highly important to keep you breathing and your heart beating. Which of the lobes is going to be responsible for vision? Occipital, good. And if we're talking about the white fibers that connect the 2 cerebral hemispheres, what do you call that tract of white fibers connecting right and left cerebral hemisphere? Corpus callosum, okay? So if some of those questions are bothering you guys, make sure that you go back and you look through some of those brain structures. I know there's a lot. That's why I tried to randomly ask questions as we go through, because I know it's easy to forget those structures, but you will see them over and over again, whether in here or in lab. So if you felt pretty comfortable with those, then good. If not, make sure you go back and do a little bit of review. So now that we've gone through the 4 different major portions to the brain, now we're going to go over the physical protection of the brain. Obviously, the neural tissue is very delicate tissue, and it is highly important that this tissue does not bang up against a very strong skull bone. So what we have are these layers of protection that are going to ensure that our neural tissue does not get hurt whenever it hits the cranial bones. Obviously, the bones are going to protect from very blunt-like traumatic forces, but we have more than just the bones that are needed to protect the brain. So we're going to walk through the cranial meninges and then the cerebrospinal fluid today. We'll get to bones later on in the semester. And then we'll also be talking about the biochemical isolation, which is the blood-brain barrier. And we'll also show you the blood cerebrospinal fluid barrier as well. So for our cranial meninges, you want to make sure that you remember the 3 layers to the meninges are called the dura, the arachnoid, and the pia. Now make a little note to yourself, this dura, this is the most superficial layer, and the pia is actually the deepest layer. So bless you. If you want to remember the acronym PAD, P-A-D, PAD is going to be the layers of meninges from deep to superficial. The pia matter is actually on the brain itself. So it will physically touch the brain. The dura matter is going to be closest to the bone. Obviously, the arachnoid is going to be in between the two. So we'll walk through all of these, but if PAD helps you, you just have to remember, if we're going to pad the brain, we're going to do so from deep to superficial, okay? Deep to superficial, P-A-D. Now, I put a little asterisk right here. These 3 cranial meninges are continuous with the spinal meninges. What this asterisk means is, although the names are going to be the exact same, you're going to see that there's going to be a difference within the dura matter inside of the cranial cavity that we will not see within the vertebral cavity. So I'll show that to you, I'll point that out and make sure that you understand that there's a little bit of a difference there whenever it comes to that dural layer between the brain versus the spinal cord. Okay, so dura. There are 2 layers here, an inner fibrous layer and an outer fibrous layer. So we would call the inner layer the meningeal dura, and the outer layer is the periosteal dura. Remember, osteon, osteum, os means bone, okay? So that O-S-T-E, that should be significant to you to say this is the layer that is closest to the bone. Periosteal, meaning around the bone. Okay, so that's why this outer fibrous layer is actually fused to the membrane that will surround the bone. This periosteum is the membrane that surrounds bone. Whenever you look at the difference in the brain versus the spinal cord, this is where your star goes, these dural folds. These are extensions of the dura into the cranial cavity. So they literally extend inside of the brain. Why? To stabilize and support it. Because if you think about your head being jerked, if you are hit in a motor vehicle accident, if your head is jerked towards maybe, let's say, the driver's side window, if you're T-boned from the passenger side and that head goes and it smashes against your driver's side window, you need something that's going to kind of be like a lock mechanism so that your brain doesn't shake inside of your cranial cavity. So you can think about these dural folds as being seat belts to the brain. They're basically going to buckle it in place so that it's stabilized and there's less movement inside of the skull whenever there is any sort of traumatic impact. Whenever we look at these extensions, these are the 3 largest ones, the falx cerebri, tentorium cerebelli, and the falx cerebelli. I'll show you a picture of those 3 here in just a second. But another important aspect to these dural folds or these extensions is that they contain the collecting veins. We call these the dural venous sinuses. So highlight this right here, dural venous sinuses, because With these extensions also comes the ability to create these sinuses, which is going to be incredibly important here in just a second when we talk about the cerebrospinal fluid. So you're not going to see these sinuses within the spinal cord. Okay, this is just a brain thing. The falx cerebri is going to contain the superior and the inferior sagittal sinus. And this extension actually goes right between the two cerebral hemispheres. Does anybody remember the name of that fissure that's going to separate right and left hemisphere? Longitudinal, very good. So it actually dips right inside of the longitudinal fissure. This falx cerebri does. So this extension just comes down from the top of the skull and goes right inside of that longitudinal fissure and sits right there between those two cerebral hemispheres, protecting that brain from excessive movement. And here in the falx cerebri is where we will find these two major sinuses. Then we have the tentorium cerebelli. So this is going to actually separate the cerebrum from the cerebellum, and it will contain the transverse sinus. If we were to do a transverse cut, like if I were to transverse cut across my abdomen, then we get two different portions, right? We get a superior and an inferior, right? So that's transverse. Whenever you look at this transverse sinus, you will see that superiorly we have the cerebrum, inferiorly we have the cerebellum. Okay, so it makes that same kind of plane across the brain, separating the superior cerebrum and the inferior cerebellum. And then we have the falx cerebelli, which will divide the cerebellar hemispheres. This is going to be below the tentorium cerebelli. So let's take a look at some pictures real quick. I'm going to come back to that in just a second. Okay, so here's the big one. Here's the falx cerebri. This is the one that's going to sit in the longitudinal fissure. Okay, up here, this dark blue line, this is your superior sagittal sinus, and this is your inferior sagittal sinus. So these sinuses, like I said, I'm going to explain in a minute why they're so important for our cerebrospinal fluid. You can see the transverse sinus right here. There are other sinuses as well, but these are the major ones that we are going to be talking about. Okay, you can see this falx cerebelli going to be separating the cerebrum from the cerebellum. But what you can't see so well, this is the falx cerebelli going in between the hemispheres. I said that backwards. Tentorium cerebelli, separating cerebrum and cerebellum. So many words, so many words. Okay. Those are our dural extensions. And what are they going to help our brain do?
Stabilize.
Stabilize. Perfect. By having these dural extensions, we also get the dural sinuses. Will you see this in the spinal cord?
No, brain only.
No, you will not. Okay? Just for the brain. So our dural layer, is it closest to the bone or closest to the nervous tissue of the brain? To the bone, exactly. So let's keep moving forward in our meninges. The arachnoid matter, this is going to look like a spider web. So that's where it gets its name from. Arachnoid, hopefully you don't have arachnophobia, but arachnoid matter looks like the actual spider web. It attaches to the dura mater. This says may be separated by the subdural space. If we're saying sub, does that mean above or below? Below, right? So subdural space, this means this would be below the dura. The reason why it says may is because the subdural space is actually a potential space. In real life, that space is not there, but if you have a trauma or you have an accident or you have like a cadaver that has basically, passed away, person's passed away, they've formaldehyde, you've got this preserved specimen, then we start to see this space open up, okay? The subarachnoid space is going to be the important space that I definitely want you to remember, because this is the space where you will have the cerebrospinal fluid flowing. So this is where your CSF is going to be. So it's very, very important space within the brain, and this will be continuous with the spinal cord. So you'll also see CSF in the subarachnoid space around the spinal cord. And then the pia mater directly attached to that brain surface by astrocytes. What you're also going to see kind of attached to the brain are going to be those cerebral blood vessels. So basically the pia mater kind of covers those blood vessels as well. So all of it is right there, nice, neat little lovely package all together. Okay, if we look at a blow-up picture, so basically what we're doing is we're taking this piece of the cranium and we're blowing it up right here. So here's the bone. This is to be the top of your skull. You can see the periosteal layer of the dura, which is closest to the bone, and then you see the meningeal layer. In between the two is the dural sinus. After that, we drop down. We can actually see this arachnoid matter looking like a spider web. And then you can see the pia mater directly attached to the cerebral cortex. So PAD, pad the brain for the purposes of protection. Okay. Now, since we're talking about cerebrospinal fluid, we have to talk about where this comes from. This is going to come from the ventricles of the brain. So whenever we're looking at the embryo, in the embryo, the neural tube encloses what's called the neuroceal. That will expand to form chambers, which become our ventricles, and these will be lined with ependymal cells. So underline that, ependymal cells, because we briefly talked about this whenever we were going through the nervous tissue. We talked a lot about the neuron, but remember the neuron is the CEO, the neuroglia are the secretaries. So this is one of our neuroglia, is these ependymal cells. Each cerebral hemisphere will contain one large lateral ventricle. So basically we have two lateral ventricles, and they will be separated by this partition that we call the septum pellucidum. The third ventricle is found in the diencephalon. So whenever you're looking at the mid-sagittal section of the brain, in the area near the thalamus and the hypothalamus is where you would find that third ventricle. And this does communicate with each of the two lateral ventricles through a structure called the interventricular foramen. If we look at a picture here, here's a lateral ventricle, here's a lateral ventricle, this is your third ventricle. So you see you would have to cut the mid-sagittal section in order to actually see this third ventricle. So here's the interventricular foramen, where fluid can flow from a lateral ventricle into the third ventricle. And then fluid continues to flow through this structure called the cerebral aqueduct to come down into the fourth ventricle, which is in between the brainstem and the cerebellum. Fluid will continue to flow through the central canal, which is going to be continuous with the spinal cord. So this is looking at it from the anterior view. We can look at it from other views as well, and I do have a video in here for you guys to kind of look at it in a 3D representation. I'm not going to play the whole video, but I'm just going to play a very short portion just so that you can kind of see it twist and move a little bit. So as I already said, the fourth ventricle is going to be connected with the actual third ventricle through the cerebral aqueduct, and it could be continuous with the central canal of the spinal cord. Here's looking at it from the lateral view. So now you can kind of see, if you look at that mid-sagittal section of the brain, the little alien looking eye that's looking at you right here, this is the interthalamic adhesion. And then this is going to be your third ventricle. Okay, so let's watch this video, just a very short portion because it kind of moves pretty slow, but just so that you can kind of get your eyes on the structure in a 3D view.
It was the night before kickoff when all through the house, not a player was standing, not even Huh? I'm not sure.
I don't think that's going to actually show.
The cerebrospinal fluid, or CSF, is the liquid that bathes the central nervous system, the brain, and the spinal cord. The CSF ensures the protection of the central nervous system against mechanical shocks and vibrations. It plays an important role in the regulation of intracranial pressure. It participates in the cerebral metabolic processes by regulating the exchange of substances and provides many other functions as well. The CSF circulates in two different compartments. The first is the inner brain ependymal cavity, or ventricles. The second is the compartment surrounding the central nervous system. It corresponds to the subarachnoid space. The CSF is secreted by the choroid plexus, clusters of capillary blood vessels located in the ventricular system.
Okay, so notice how these choroid plexuses are going to be in each of the ventricles. So you can see the clusters of the capillaries within the lateral ventricles, the third ventricle, and the fourth ventricle. So the choroid plexus is where the CSF is actually going to be coming from. That makes it a very important structure. So this choroid plexus, you definitely want to remember that it is what is going to be responsible for producing our cerebrospinal fluid. And I do have some slides that will talk more about the choroid plexus, but I just wanted to show you from this particular view right here. So what is this long structure here called? Lateral ventricle. What is this one? Third. And what is this one? Fourth. Good. And if we keep going down, ultimately, this is going to become the spinal cord further down this way. But this little structure right here, this is going to be the central canal. So through the ventricular system, we will be able to bathe the brain in the cerebrospinal fluid and also allow that fluid to come down into the spinal cord as well. So you'll be seeing the central canal as a structure we'll be studying whenever it comes to the spinal cord. Do not get it confused with the central canal of bone. In the central canal of bone, that's where you will have arteries and veins for the purposes of blood flow and vascularizing the bone, but the central canal in the spinal cord is for cerebrospinal fluid. Same name, different structures though, okay? Oops. So now that you've seen the ventricular system a little bit, if you want to go back and you want to look at that video, it just keeps kind of going through and talking about the names of the different ventricles and how to appropriately label them. But let's talk about the cerebrospinal fluid. This is incredibly important because this will help support the brain, and it acts as a cushion of water that allows you to hold your head up. So if we did not have the cerebrospinal fluid, our brain would actually be too heavy for us to hold up by ourselves. So it provides that level of buoyancy that makes the brain lighter than it actually is. So it's supportive, it's very cushiony, and it will also help with transporting nutrients, chemical messengers, and waste. So vitally important in helping to maintain homeostasis within the brain. As I said, the choroid plexus is going to produce the cerebrospinal fluid from the specialized ependymal cells that surround the capillaries within the ventricles. So every day it will secrete about 500 mils of CSF into the ventricles. At any one point in time, we normally have about 150 mils on our brain, or I should say within our central nervous system. So not all 500 mils are going to be in there at the same time. Generally, it's going to be replaced about every 8 hours. So about 3 times a day, you're going to be getting fresh, new, healthy cerebral spinal fluid. It will remove waste products from the CSF, the choroid plexus will, and adjust the composition of the CSF, because in order to maintain homeostasis within the neural tissue, we have to make sure that there are the right amounts of potassium and sodium and chloride and all of those very vital ions that will allow the neurons to go through the action potential like they're supposed to. So that's how it's going to be very important to maintaining homeostasis in the brain. Yes, ma'am.
So where does it go when it leaves? Sorry.
Good question. Where does it go when it leaves? That's coming.
Okay.
You're 3 steps ahead. Okay, so again, choroid plexus will produce and maintain the CSF. If you're looking at this particular picture, what you're seeing here is this is representation of our choroid plexus, and what I want you to actually put your eyes on are going to be these ependymal cells. So you see these cuboidal looking cells with these microvilli structures on top of them. They have tight junctions, which means they are very, very, very close together. And they're being incredibly selective about what is going to be able to come in or out of this particular blood capillary right here. Okay? So whenever we're looking at the CSF, as I kind of alluded to a little bit earlier, it will circulate from the choroid plexus through the ventricles and then down into the central canal of the spinal cord. Remember, it will also go into the subarachnoid space, and it does this through these 2 lateral apertures and a median aperture within that 4th ventricle. Why does it need to get into the subarachnoid space? To completely surround the brain, the spinal cord, and we'll be talking about the cauda equina when we get into the chapter for spinal cord. So here's a picture showing you representations of the CSF flowing out of the ventricles, getting into the central canal, as well as into the subarachnoid space. So all of the little red arrows that you see are all flow of CSF. It has to bathe this entire brain and spinal cord because it has so many imperative jobs to do. So we want to make sure that it is working appropriately. It is possible to have a loss of CSF. I actually had, it's rare, it's very rare. I think it's like 5 in 100,000 people or something like that, so rare. But I actually had a student one semester who had to leave school because she got a lumbar puncture for them to figure out why she was having the migraines that she was having. And her puncture did not go well. And she was continuously leaking CSF, which actually is the cause of further perpetuating headaches, because if you don't have enough of the fluid with the buoyancy of the brain, it causes that pressure to change inside of your head and actually will create more headaches. So she ended up having to leave school. I don't know what happened to her, poor thing, but she struggled a lot with the leaking of the CSF. So again, one of those things that we take advantage of until we don't have it anymore and it's not working as it's supposed to. Yes, ma'am.
How does it leak? Is it just like due to trauma, or?
It can leak through trauma, yes. In her particular case, it's because the procedure was done incorrectly, and so it did not heal and did not close properly, so it just kept coming out of her back.
Oh my God.
Which is unfortunate. But yes, there's situations like trauma, or if the dura gets torn in a particular place or location. Sometimes this will happen with people with like connective tissue disorders. If that dura has a little tear in it, then it can seep out of the dura, and then that's why that balance cannot be maintained like it's supposed to. Okay, so to answer the question, so where does this go whenever we're done with it, since it's being replaced constantly throughout the day? You want to make sure that you know these two terms, arachnoid villi and arachnoid granulations. So especially the granulations, because these are large clusters of the arachnoid villi. And what you're going to see here is that these will actually extend through the dura and actually protrude into the superior sagittal sinus that I showed you guys earlier. Whenever they protrude into the superior sagittal sinus, what's going to happen is pressure is going to force the cerebrospinal fluid to go into those dural sinuses, and then it will be in the venous circulation. So let's take a look at a picture here. Here's an arachnoid granulation. The red arrows are showing you how under a force of pressure, the fluid is going to come out of the subarachnoid space and get into the superior sagittal sinus. The superior sagittal sinus is ultimately going to drain through other sinuses within the brain, and then it ends up in the internal jugular vein, which is going to feed back into the cardiovascular system. So this fluid has to drain off of our brain, out of the CNS, and it will find its way into the cardiovascular system via the internal jugular vein. So that's how we constantly have this secretion, reabsorption happening appropriately like it's supposed to. If there's ever a problem with these arachnoid granulations, then what will happen to the CSF within our brain? What do you guys think?
It would build up.
It's going to build up. Yeah. If these are not working appropriately, it's not going to allow the CSF to drain off into the sinuses. So this is when you will get the condition called hydrocephalus, where you have basically like a head the shape of a watermelon, because you have so much water on your brain that it's building up and it's not draining off. It doesn't have anywhere to go. So interestingly, I had a different student. See, I love whenever you guys tell me these things. Interestingly, I had a different student whose child had problems with the arachnoid granulations, and they couldn't figure out why it wouldn't drain. They didn't know what was going on. So obviously there had to be some surgical procedures that were done in order to help this child drain the fluid off of her brain so that she did not have to deal with that hydrocephalus. So arachnoid granulations, small but mighty and powerful to keep our normal level of CSF within our CNS. Okay, I've already said the dural folds will hold the brain in position like a seat belt. We talked about three. Remember the falx cerebri, falx cerebelli, tutorium cerebelli. Protect it from damage. The CSF will cushion the brain. Also think about like whenever a mom is pregnant, how whenever she is carrying the baby, what is around the baby? What is that fluid called? Do you guys know? Amniotic fluid, exactly. So that is like a protective cushion to that baby as well. If somebody runs into mom or like bangs her belly on accident, then that physics means that whenever the forces are flowing through her abdomen, that fluid can kind of cushion the blow so that it doesn't hurt the baby. So it kind of takes that jolt. So same thing is going to happen with the fluid on our brain, protecting it against those sudden jolts. We talked already a little bit about cranial trauma. So with the concussions, with the traumatic brain injuries, obviously those are real deals. Those things do happen because despite the protective nature of the meninges and the CSF, we still kind of get ourselves involved in these crazy sports, or there's motor vehicle accidents. So dizziness, nausea, vomiting, blurry vision, headache, trouble thinking clearly are all signs that if you've had some sort of traumatic impact to your brain, you definitely do want to get that assessed. Don't just think that it's going to go away all by itself, because sometimes it does not. Okay. Blood supply to the brain. Internal carotid arteries and vertebral arteries are actually going to deliver the blood up to the brain. The carotids you can use to kind of feel your pulse, so those are pretty easy to feel within the neck. And then for the vertebral arteries, You will see as we get later on into 2402, they're very easy to identify because they are going to run up the cervical bones within the spinal column. So very easy to see those. That's right here within the spinal column. So the internal carotid and the vertebral arteries are going to be carrying the blood into the brain. In 2402, we'll talk about the circle of Willis, which is all of these structures that you see right here that are going to ensure that the blood has plenty of oxygen and nutrients at all times. Obviously, if blood supply is ever interfered with, then we are going to have some major issues. If you have blood supply that gets cut off and your brain is not getting the oxygen and nutrients that it needs, we call that an ischemic stroke. ICHEMIC. ISCHEMIC. Ischemic. Hold on. ISCHEMIC. Ischemic stroke. That's whenever blood supply is cut off. Okay. If, however, you have an aneurysm that ruptures, that's a hemorrhagic stroke. That means that blood is now bleeding into the tissues of the brain where it is not supposed to be, and it will put pressure on that actual neural tissue, and it can actually then cause those other blood vessels to constrict, and they can now no longer get blood to the brain as well. So ischemic stroke is an interruption in supply. Hemorrhagic stroke is less likely to happen. However, hemorrhagic stroke is more likely to cause fatality. So whenever we're looking at any issues that can cause a stroke, also known as a CVA, if there is any issues with blood flow to the brain, affected neurons begin to die within minutes. This does not take long at all. So a few minutes and the clock is ticking, okay? So that's why the acronym for stroke is FAST. Like you literally have to think fast. So it's F is for facial drooping. If you see somebody whose face starts to droop, especially if it's just on one side. A is for arm weakness. So if all of a sudden they feel like they cannot move their arm, got to think about that. S is for speech. If they start slurring their words, they are no longer talking in coherent sentences. That is the S. And then T is for time. Hurry up and call 911 as fast as you can. Okay? So facial drooping, arm weakness, speech, and time. You are on the clock because these neurons are already dying if you're already seeing these things. You can see here this aneurysm is a bulge in an arterial wall. This is what causes the hemorrhagic stroke. So if this bulge were to burst, then all of the blood that's within this artery is going to come out into the brain. And because arterial pressure is much higher than venous pressure, this is why this is more likely to be associated with the fatality. Okay, there's too much pressure of blood on the brain that's not supposed to be there. So there can be aneurysms in multiple different locations. You may just have one. I had a friend whose really close friend's husband died. They found 42 aneurysms inside of this guy's brain, which is outlandish. The fact that he even made it as long as he did, I don't really know how he was able to do that, but they can be in the brain, they can be in other places like the abdomen. There's lots of places where they can be. So basically what this is a weakened arterial wall. And when that arterial wall is weak, it will start to bulge. If it becomes too weak and the bulge breaks, then that's whenever we have our CVA. The unfortunate part about this is that ruptured brain aneurysms are fatal in about 40% of cases, and of those who do survive, about 66% will suffer some permanent neurological deficit. approximately 15% of patients will die before they even get to the hospital. So this does happen very quickly. Actually, whenever I was 19 years old and my son was 1, his father had a brain aneurysm. And this is one of the reasons why whenever I teach you guys, I teach you from the aspect of you have to learn how to listen, and why I like for you guys to take notes and to take things in and really try to work your neurons in such a way that you don't need to go back and listen to something 18,000 times in order for you to get it, because you want to be able to be fast when you get in the medical field. So whenever this particular incident happened to him, actually, we just thought that it was just a hangover because he used to get drunk all the time. And mind you, I'm 19 years old. I really don't know much of anything at this point in time. So whenever he came home and he was throwing up, I just suspected this was just another situation of him doing stupid stuff and, you know, whatever, just have to get through it. He did have to go to work every Sunday. This was a Friday. So Saturday comes around and I'm looking at him like, you know, maybe we should do something because you don't seem like you're getting any better. It seems like it's getting worse. And I knew that the only way that I could convince him to go into the doctor would be to say, you're going to miss work, because he never wanted to miss work. So he was like, no, I'll be fine. I'll be fine. I had to go to work on Saturday. I left. I forgot something at home. Thank God I forgot something at home. I came back. And this is what I came back to. He was sitting in a chair, and so he's sitting down, and he kind of had like his legs kind of like, you know, shoulder width apart. And I see my son, who is 1 at the time, I see my son standing in front of him, and his dad is trying to get him dressed. And so like he's trying to put these shorts on him. And I look down, and in between him and my son, there's a trash can. And I'm wondering what's going on. And then I see him just bend over, and he just vomits completely in this trash can. And so I was like, okay, this is not good. So I go in, I get my child. I'm like, what are you doing? I don't understand why this is happening. Like, what's going on right now? He was like, well, my mom's on the way, but I had to get him dressed before she got here. Okay, I'm gonna take care of this situation, and you go in there and you lay down. Your mom is coming, we'll work this out in just a minute. And he was like, I don't think I can make it to the bed. And so I'm like, okay, why? And he said, because I can't really see that great. Like my eyes, my vision is blurry. And so I'm thinking, okay, he's telling me his vision is blurry. He has this vomiting. The day before yesterday, whenever I had bought him this Advil, it said on the bottle, tell your doctor this is the worst headache you've ever experienced in your life. And so all of these things start adding up in my brain. I was like, get up, we're leaving. Take him to the ER. I'm not even gonna wait on the mom. Take him to the ER. I check in at the front desk and I tell the woman, he has blurry vision. This is the worst headache he's ever had in his life. And he's vomiting. I have to go pee though, so can you show me where the restroom is? And she's like, yes. And so I leave my son with him. The restroom is literally like 20 steps away. I go to the restroom, come back, they're gone. And so I start freaking out. I'm like, where's my kid? What happened? I don't understand. Like, we just checked in. Well, this is what it was. The nurse heard the 3 things that I said and immediately responded because she knew we have very little time. And I don't know what's going on in this man's head, but she immediately, as soon as I walked in the restroom, came, wheeled him out, had already taken him down to radiology, and he was getting his brain scanned in that very moment. So there was no waiting around. Turns out, yep, massive bleed. He's been bleeding since Friday. This is Saturday. This is Wilson and Jones in Sherman, Texas. They can't handle this. They call Parkland, we get a helicopter, here comes mom, she's beside herself, doesn't know what to do. We're all driving down to Dallas from Sherman. She drives my car, she's on the frontage road of 635, weaving in and out of gravel. I'm like, Lord, please don't let us die. You know, we're not gonna be the only deaths today. I called my mom. I'm like, oh my gosh, this is what's happening. My mom is a physical therapist. She's been around a lot of stroke patients, so she knows about 2% is what she said. He's probably got a 2% chance to live because he's been bleeding for so long. And she said, I'm not gonna lie to you. My mom has never sugarcoated anything, but in that moment, I kind of wanted her to a little bit. She was like, you'll be fine. It's gonna be okay. You can do this. You know, make it through. And I'm like, okay, I could do this. We get to the hospital and the surgeons are, you know, they're wonderful. They come out and they say, look, we're going to be in here for a lot of hours. Okay, it's going to take us a long time because there's a lot of blood. There's a lot of stuff that's going on that we're going to have to clean up. So we might be in here for 16 hours. They start calling people. And this is why I talk to y'all the way that I do, because this experience changed my life. They start calling people, and I see all of these people come up to Parkland from Sherman, and they are all in this circle inside of the waiting room. Had to have been 30, 40 people, and the pastor of his dad's church is there, and he starts leading everybody in prayer. And I remember this like it was yesterday, even though my son is now 19. And I said, I don't know anything about what they're doing. I have no idea what's going on. I don't even know what they're saying. Lord, I don't know who you are. I wasn't raised in a religious or spiritual household. We never did any of that stuff, never talked about it. I said, but if there's one thing I know, I was raised without a dad, and I don't want my son to do it too. And if you will save his life, I will give you mine. And every Sunday I will be at church, and I will do whatever you ever ask me to do my whole life if you will save my son's father. Because he needs his dad. I know what it's like to not have a dad. So I didn't know bargaining was not okay. Okay, so don't judge me. So I closed my eyes and I was like, that's all I have to say. I don't know what else to say. Open up my eyes. Hours go by. They come out, smiles on their faces. They're out early, way earlier than 16 hours. They said everything went good. We stopped the bleed. He's going to be fine. Half of his head has been shaved, and you will see staples from the front all the way to the back, but he is going to be okay. He will need therapy, and he will probably go back to a 3rd grade level. So somebody will have to take him to therapy every single week, and you know who that somebody was. That was me. And they gave me all the paperwork, and they said, this is what you need to do, and this is how you have to care for him, and just, you know, expect it to be like a whole new child. And so we started the therapy thing. And he went to one session and they were like, oh, you're actually pretty good. It's not bad. And we went to the second session and they were like, yeah, we thought maybe it was a fluke the first time around, but this looks okay. 3rd session, sir, you're not going to be able to stay. You have no neurological deficits. There's nothing wrong with you. You're 100% fine. And so we walked out of that therapy office that day with a completely fine brain, despite hours of him bleeding, despite all of these statistics. It was then that I learned that the master physician has other things that he will sometimes want to say. And so that changed my life. And that's why I talk to you guys the way that I do, because there are times in medical care where you will see things that are completely unexpected. I'm like, there's no way that could have happened, but it does, and it happens every single day. And there are miracles that are walking around you every single day. And I tell this story to let you guys know that even whenever things seem like it's going to be hopeless, at the end of the day, there is still hope. I thought that my mom was right. 2% chance of him surviving and a high chance of him having permanent deficit. He's fine. He's still walking around to this day. And I thank God that we're not walking around together because he made some continual decisions that were not good. Alcohol can definitely hurt your arteries. And alcohol is something that you have to stay away from if there is a history of family aneurysms. So that is one thing that I could not accept, was that he continued to go down the same path that he went along before, and I had to go down a new path. And so I want you guys to be encouraged and to know that even if things seem really grim and the statistics look really bad, that it's not over until the master physician puts his hand on it and maybe does some mighty work. So that's why I said all of that. Okay. brain-blood barrier. This is a wonderful and remarkable thing that whenever we even look at this, the fact that this can even happen to me is just like mind-blowing. So here we have this capillary, and if you're looking at this capillary, what I want you to see is right here, there isn't any space between this endothelial cell within this capillary. You can see right here, there's not any space. So what you want to know is that these endothelial cells form these very tight junctions, and the endothelial cells will form the tight junctions under the influence of these astrocytes that are right here, also lining the capillary with these very tight junctions. This is one of the instances where when you look at the blood-brain barrier, one thing that you can think of is this is the most exclusive club in the world, okay? The guards that sit at these doors only allow very select things in or out. So the endothelial cells being very tight, the astrocytes being very tight, means that only certain things, these lipid-soluble compounds like oxygen and carbon dioxide, etc., can diffuse into the interstitial fluid of the central nervous system. And like I said, those astrocytes will help regulate that by releasing these chemicals that control the permeability of the endothelium. So these very tight junctions means that if you don't look right, if you don't talk right, if you don't sound right, then you're not coming in. And that's just the way that it is, because they're trying to protect the brain from any toxins, pathogens, very harmful chemicals. We don't want anything that's in general circulation to also end up in the bloodstream and then potentially damage the neurons in the area and affect the entire brain. So here's a little picture for you. This is what a normal blood vessel kind of looks like. You can see that there is the ability for things to come in and out. There's not such tight regulation as there is right here with this tight regulation in the brain blood vessels, okay? Here's a little video right here that if you want to watch this, this will explain more about those tight junctions and the endothelial cells within the capillaries, as well as the astrocytes and the role that they play in maintaining this. So again, you can see a picture of it right here, blood-brain barrier, but there's also something called the blood-CSF barrier. So in this blood-CSF barrier, you can see this capillary right here, but this goes back to the picture that I showed you earlier. These ependymal cells are going to surround the capillaries whenever it comes to the blood-CSF barrier. So in the blood-brain barrier, it's the endothelial cells of the actual capillary that are really, really tightly regulating. It's those guards at the door that are like, no, you can't come in. But in the CSF barrier, the blood CSF barrier, it's these ependymal cells that are creating these tight junctions that are being the guards that are saying, no, you cannot come in. And again, that's because if we have certain levels of sodium, potassium, these various ions that are going crazy and they're just coming in and out, flowing however they want, either via the rules of diffusion or transport, they're gonna mess up what the neuron actually needs in order to have the action potentials. Remember, we said the neurons have to have a resting membrane potential of -70, and that's established not just by the channels, but also by the sodium potassium pump. So we have to keep things very, very tightly regulated in different parts of the brain in order to maintain homeostasis all the way around. So again, the blood CSF barrier, it's the ependymal cells connected by tight junctions that make sure that they are definitely regulating what can go into or out of that CSF. This allows the chemical composition of blood and CSF to differ. When you get in 2402, you'll learn that the pH of blood has to be somewhere between 7.35 and 7.45. So 7.35 and 7.45 are very important numbers in clinical practice, because if you take the pH of someone's blood and they're outside of that range, well, there's a lot of things that can happen if you're below 7.35 and a lot of things that can happen if you're above 7.45. So you have to know what can happen whichever way you go. But the CSF is a little bit lower than that 7.35. It normally sits around 7.3. So it has its own regulation that needs to happen as well. And that blood CSF barrier will allow that to actually happen. There are breaks in the blood-brain barrier. So these are the 4 portions where you will not have that same blood-brain barrier with that tightly regulated control with those guards. And the reason why is because these areas, you want to think about, like for the first 3, hormones. Hormones have to use the bloodstream in order for them to move from the brain to the rest of the body. So they need direct access to the bloodstream, which means that in these areas right here where we're going to be releasing hormones. What hormone does the pineal gland release? You guys remember? Makes you sleep? Melatonin, perfect. Okay. Those hormones have to have access to the bloodstream. So they need to have a little bit of difference in those portions of the brain versus the other portions of the brain where you don't have those hormones that need the bloodstream to move. And then the choroid plexus, we already talked about that. Those ependymal cells will maintain that blood CSF barrier in order to make sure that homeostasis is maintained so that CSF can provide the whole central nervous system with the proper amounts of ions, nutrients, etc. Okay, so I know that was a lot, but as we are finishing up this particular PowerPoint for brain, does anybody have any questions, whether it's just this PowerPoint or whether it is the other PowerPoints? Does anybody have any questions that they want to ask about anything in relation to the brain? Because we're going to be moving forward in the next class.